In severe cases of vaginismus, the patient elevates her buttocks and closes her thighs to prevent vaginal examination, and in extreme cases, in addition to generalized retreat, there will be visceral reactions like palpitations, hyperventilation, and even a desire to attack the doctor. A very good morning to all. Yes. First of all, let me thank the organizers for giving me an opportunity to talk on this topic. So, without wasting much time, I will go to my topic proper, Vaginismus, a diagnostic framework. So, I will be discussing my topic under the following headings: Introduction, Vaginismus, Challenges in the Diagnosis, our proposed diagnostic criteria, and finally the conclusion. So, female sexual dysfunction, even though a widespread condition, is least addressed in clinical practice, and vaginismus is an important female sexual dysfunction, and the term vaginismus was coined by James Marion Sims in 1862. So, vaginismus is defined by DSM-4 as a recurrent or persistent involuntary spasm of the musculature of outer third of vagina which interferes with coitus and causes significant distress and interpersonal difficulty, whereas dyspareunia is characterized by genital and or pelvic pain. So, all effort should be made to differentiate between vaginismus and dyspareunia, and because of the challenges in differentiating these two, DSM-5 combined them into a single entity called genitopelvic pain or penetration disorder. Dyspareunia, as we all know, is caused by physical or medical factors, whereas vaginismus is caused mainly by psychological factors. And dyspareunia is associated with sexual abuse, whereas vaginismus is related to sexual and emotional abuse. Treatment of dyspareunia includes addressing the underlying cause and of course the pain management, whereas treatment of vaginismus focus on alleviating the fear and the associated pelvic muscle spasms. And because the treatment approach in these two conditions differ, and proper diagnosis should be made. So, there are several challenges in diagnosis of vaginismus. According to definition, involuntary muscle spasm of vaginal musculature is an important requirement for the diagnosis of vaginismus, but in one study, only 28% of vaginismus group had vaginal muscle spasms and only 24% had spasms during attempted sexual intercourse. Similarly, two independent gynecologists agreed on the diagnosis of vaginismus only 40% of the time, adding to the diagnostic confusion. On induction of vaginismus reflex with a surface EMG, SEMG or needle electromyography revealed higher vaginal or pelvic muscle tone in the vaginismus group than the control group. However, other studies have failed to show increased muscle spasms in people with vaginismus, further adding to the diagnostic confusion. Although some people regard pain to be a factor in the diagnosis of vaginismus, various professional groups like DSM, ACOS, IASP and WHO do not include it in their criteria. So, the excessive dread of pain during the penetration is a common symptom reported by people with vaginismus. So, vaginismus is basically it's a phobia. As we all know, phobia is a marked and persistent fear that is excessive or unreasonable, that is triggered by the presence or even mere anticipation of a specific object or situation. People with dyspareunia experience pain, but they do not avoid vaginal penetration situations in contrast to those with vaginismus. So, next is about provoked vestibular dynia. Provoked vestibular dynia is a subtype of dyspareunia where patients develop severe intense burning pain on vestibular touch or attempted vaginal entry with symptoms like vaginismus such as increased pelvic or vaginal muscle tone. Whereas vaginismus is a phobic disorder, and this helps to differentiate between these two. But PVD often causes superficial dyspareunia and it can be detected with a cotton swab test. And according to one study, 72% of women with vaginismus had dyspareunia symptoms and 47% of women with dyspareunia had vaginismus symptoms. So, before diagnosing vaginismus, we have to always rule out secondary causes in women who has difficulty penetrating despite their expressed wish to do so. Where people in vaginismus, they refuse vaginal examinations because they are afraid of being penetrated. There is another entity called pseudo-vaginismus, where some people deliberately refuse vaginal penetrative intercourse with their partner for reasons such as spouse rejection and extramarital relationships. In such conditions, during clinical examination, they purposefully refuse vaginal examination and saying reasons like fear or pain. So differentiating between people who claim to have difficulties in allowing vaginal penetration and true vaginismus is really challenging and requires multiple sessions of detailed history collection and clinical evaluation. So some of these people might be misdiagnosed with vaginismus. This is called pseudo-vaginismus. The most common clinical manifestation of vaginismus is difficulty in vaginal penetration, which is typically associated with fear or emotional distress. So during attempted penetration, the female partner complains of fear, pain and discomfort, and the male partner is unable to penetrate and generally feels like he is hitting a wall. So typically after prolonged attempts to penetrate, the male partner would lose erection and leading to a misdiagnosis of erectile dysfunction in the male partner. So sometimes a couple will present to an infertility clinic with an unconsummated marriage. So coming to our proposed diagnostic criteria, increased muscle spasm on vaginal examination could be due to partial vaginismus, or there is sometimes complete inability to perform vaginal examination, that is total vaginismus. So this is an objective clinical criterion for making the diagnosis of vaginismus. So EMG or needle EMG might show same result confirming the diagnosis of vaginismus, that is the laboratory criteria. According to the proposed diagnostic criteria, the presence of one of the objective clinical or laboratory criteria is essential for the diagnosis of vaginismus. In severe cases of vaginismus, the patient elevates her buttocks and closes her thighs to prevent vaginal examination, and in extreme cases, in addition to generalized retreat, there will be visceral reactions like palpitations, hyperventilation and even a desire to attack the doctor. So genital examination not only confirms increased muscle tone but also rules out secondary causes of pain on penetration in persons with suspected vaginismus. So associated sexual distress and interpersonal problems are included in the diagnosis of vaginismus in DSM definition, but these are not included in our proposed diagnostic criteria. We believe that distress developed due to vaginismus, and distress is influenced by various factors such as interpersonal relationship and socio-cultural factors. Therefore, according to the proposed criteria, distress is not required for the diagnosis of vaginismus. Next is about the frequency duration criteria. That is the persistence of symptoms for more than 50% of the time for a period of 6 months or longer, and those who do not meet the frequency duration criteria are diagnosed with the transient vaginismus. And transient vaginismus include situational vaginismus. Vaginismus, as I already told, is a phobic disorder, whereas dyspareunia is a pain disorder, and some people with painful genital conditions experience pain and spasms that are out of proportion to the underlying condition, resulting in the phobic fear of penetration. The condition better called as dyspareunia vaginismus overlap syndrome. So there will be features of both dyspareunia and vaginismus. So this is the graphical representation of the vaginismus dyspareunia overlap syndrome, where the left hand side it is pure vaginismus and the right side it is pure dyspareunia, and in between is the vaginismus dyspareunia overlap syndrome. So this is the same. Dyspareunia and vaginismus are treated differently. Therefore, it is essential to assess the contribution of each component and make a clear diagnosis to plan proper treatment. So according to our newly proposed criteria, those who meet the subjective, objective and the frequency duration criteria and the exclusion criteria are classified as having vaginismus, whereas those who meet the frequency duration criteria, those who do not meet the frequency duration criteria are classified as having transient vaginismus, and those who have features of vaginismus and dyspareunia are diagnosed with vaginismus dyspareunia overlap syndrome. So coming to the proposed diagnostic criteria, there is a subjective criteria, there is an objective criteria in which there is a clinical and a laboratory criteria, and there is a frequency duration criteria, and there is an exclusion criteria. Subjective criteria is the same, the definition of vaginismus, as I already told: persistence and recurrent difficulty or inability to allow vaginal entry of penis, fingers or any object despite the expressed wish of the female partner due to emotional distress or fear of pain on anticipation or attempted penetration that is excessive and unreasonable, leading to variable avoidance of vaginal penetration. The objective criteria, in this the clinical criteria: muscle spasm during vaginal clinical examination, like marked tensing and tightening of pelvic floor muscle during attempted vaginal intercourse or penetration. And the laboratory criteria: increased muscle tone in an EMG study during induction of vaginismus by a vaginal dilator or attempted penetration. Frequency duration criteria: symptoms persist for 6 months or more with the inability or difficulty to penetrate during the majority of attempts, that is more than 50%. Exclusion criteria: there should not be any secondary cause for pain or difficulty in penetration, like gynecological causes like vaginitis, vulvitis, even UTI, pelvic inflammatory disease, endometriosis, like that. So this is the interpretation of the diagnostic criteria. When all criteria are met, it is true vaginismus, and if the frequency duration criteria is not there and the subjective criteria, if there is no symptom from the patient side, it is asymptomatic vaginismus, and if there is no all features are there without the frequency duration criteria, it is the transient vaginismus. And there is objective criteria, frequency duration criteria with features of dyspareunia, it is the vaginous dyspareunia overlap syndrome. And if the same without frequency duration criteria, it is the transient vaginismus dyspareunia overlap syndrome. And another case is probable vaginismus. In this, the objective criteria is not there, but the subjective criteria and the frequency duration criteria and the exclusion criteria is there. And without the objective criteria and the frequency duration criteria, it is probable transient vaginismus. So this is our journal. It got published in an Index PubMed journal. It is available online. So we expect that the proposed diagnostic criteria would be useful for practicing clinicians worldwide in confidently diagnosing vaginismus and providing appropriate care to those in need. Thank you for the patient listening.
Thank you so much, Dr. Rajini, for clarifying the important topic. Now, due to lack of time, we will take only one question. Any question from audience? Okay, we'll move on next topic.
Thank you.
Thank you, ma'am. And we request our chairpersons to felicitate our speaker, Dr. Rajini, ma'am. Dr. Rajini, ma'am, please.